Alright, hi guys, a very good evening to all of you and welcome to our today's YouTube session where we shall be talking about some of the important clinical cases, and we have given them the title at most expected MCQs. And what I am trying to clarify here is not the MCQ per se which is important, but the topic which we are going to cover here in this session, which will be very important. So this is going to be a 1 hour session in which we shall be discussing some very crucial, very important topics in the clinical based sessions. So I'll be starting this session very quickly, but before that I need a quick confirmation from you. If I'm clearly audible and visible, please comment on this live comment section here. If everything is fine, just give me a quick thumbs. If everything is fine, please reply here so we can immediately start. Okay, great. So a couple of announcements that I'm having about the upcoming session that we have, and also some special classes, free session, free tests that are there on the platform, which I'll be discussing here. Now this is one of them, that is NEET PG free test for April 2022. These are the different tests that we had, like mixed image based question that will be conducted tomorrow, April 30, educator curated physiology, April 30 again, and then tonight 9 p.m. I think you had your gynae test. So these are the different tests, and for some of the student, if they are going to ask you the code, you can use the same code, that is Pharma 10, to unlock this test. These are absolutely free for all of you guys. All India mock test 2022, again a very crucial test. So everyone, I would recommend every student to attend this test, be it INICT, NEET PG, and also FMGs should also attend this one. And if they are going to ask you the code, you can use the same code, that is Pharma 10, to unlock this test. All right. So this is one of the important offer that was going on. You can use the code again for the Pharma 10 as well. So there were some offer going on that if you are going to subscribe till April 30, you will be getting at least a 20% off in your subscription. So Pharma 10 will be your code to avail the same offer, like not 10% but 20% till April 30, that is going on. They are the different subscription duration and charges that they have for the platform, and this is for the iconic subscription. Light subscription is mainly for test and discussion batch, test series kind of batch, where you will have grand test, subject wise, topic wise test available will be there. And MBBS 1 year subscription, this is mainly for the first year students, and also in upcoming days there will be session for the second year and third years as well. This is the one that I was talking about, Prof 1, which has started April 25 till April 25, 28, 2022. These are the dates on which they are going to be started, and you can use the same code, that is Pharma 10, to avail a 10% off. This is about light, where you can actually practice all the test series, and plus subscription, you will have everything in Unacademy. You will have access to everything on the platform. Iconic subscription, you'll have access to Unacademy, and also you'll have access to Prep Ladder as well. Unacademy and Prep Ladder, you'll have access to both of them. The NEET PG PYQ, where you will find at least 4-year PYQs of NEET PG, INICT and FMGE, and you can practice so that you can understand what is the mindset of the examiner about a particular topic or a particular question, how the questions are framed, and accordingly when you go back to your notes, you will be able to comprehend that what kind of question can be framed from a particular topic that we have. Okay, daily practice paper is for plus students, where after every class they can actually practice a couple of questions, like 5 to 10 questions after every class, so that at least they will be able to understand that whatever they have learned in the class, are they able to apply it on the MCQs or not. So this is another very unique feature on the platform. Okay, then we are having this new topic, that is frequently forgotten and volatile topics, and also on the emergency medicine, and in pharma we have also in biochemistry, in PSM and Dr. Medicine, and also in the anatomy, in different subjects. We are having this 10-day revision course that is going on, and it will be starting on May 4. So for pharma, I'll be covering some of the important topics which I feel that very important, and students often tend to make mistake. So this will be 2 sessions in 4 hours. This will be May 4-5 ko start ho raha hai. My session will be starting somewhere in the first week only. You guys can check that out. Okay, so after this short introduction about the different offerings on the platform, I think it's time for us to start. I think there was some issue with the there was no notification sent, I guess. Okay, we'll be starting that, but I think was there any issue with the notification? I don't see any notification. So maybe some of the students, those who cannot get the notification, they'll be watching it later on, I believe. Okay, maybe there is some issue, some technical reason, but I hope all the students, those who are live, I'm clearly audible and visible to all of you guys. Let's get started. So the first question that I'll be asking from a very basic, and after that we have all the clinical cases. So one question I have taken from General Pharma: which of the following is true for receptor and action of a drug? With respect to receptor and action of a drug, like different kind of drugs are there, and different kinds of action will be seen on the receptor, like some of them are agonist, antagonist, partial agonist. Look at this question and let me know which of the following do you think is a true statement. Important topic. Okay, like G protein, receptors, different kind of drug, different kind of antagonist, like competitive, non-competitive, physiological, chemical, these are very crucial topic. Always ask question. Please let me know your answers. An antagonist has both intrinsic activity and affinity for receptor. Intrinsic activity and affinity are not important for drug action, is it? An antagonist has affinity but no intrinsic activity for a receptor. A partial agonist has no intrinsic activity or affinity for a receptor. Please go ahead. So this is a 1 hour straight session. 1 घंटे straight we'll be talking about the clinical cases and the important MCQs. So some of you are actually marking C. Other students also, please keep on replying to your comments for all those who are live right now. Now when they say different kinds of drug and receptor antagonist, so different kinds of drug that we are having, let us say agonist, full agonist, that is producing maximal intrinsic activity, or we are having partial agonist, or we are having antagonist. What is one thing that is common? And also inverse agonist. So if they are acting at the same receptor, what is one thing that is common for all of them, guys? They all are having high affinity. They all are having affinity for the receptor. Receptor के लिए affinity है, but they all are going to have different intrinsic activity. Affinity is ability to bind with the receptor, but intrinsic activity will be different. Like antagonist will have an intrinsic activity score of 0, and if I see agonist का intrinsic activity score, I can just write it quickly. It will be producing maximal intrinsic activity. Okay, so agonist will have intrinsic activity score of +1, 100% activity. Partial agonist anywhere between 0 to 1. Antagonist will have 0, and inverse agonist or negative action -1. So when you read antagonist has both intrinsic activity, that's a fishy. Antagonist does not have intrinsic activity, 0 intrinsic activity. Affinity to have, but 0 intrinsic activity. 0 intrinsic activity. So this will be not true, I would say. Intrinsic activity and affinity are not important. Is it not important? Definitely it is important for drug action. See, an antagonist has affinity, it will have affinity, okay, and no intrinsic activity. It simply occupies and does not produce any intrinsic activity, okay, neither partial, neither inverse. So no intrinsic activity. C, I believe some of you have given the answer correctly. C is the correct one. Now partial agonist has no intrinsic activity. That's wrong. It has intrinsic activity, although it's going on the negative side, but it has intrinsic activity. Or affinity, it has affinity also. So this is actually a wrong statement. You have to choose one true. So I believe that C is the correct one, and if this is going to be asked in the examination, you guys can easily mark. So they can give you a graph like this as well, and they can ask you that this is the 100% response and minus 100% response. So this will be an agonist, full agonist. Then somewhere here will be your partial agonist, and antagonist will have this one. This will be your antagonist, and they will have ability to bind with the receptor and does not produce intrinsic activity. And here it is going to be your inverse agonist. So I'm afraid that, let's say they can give you a graph something like this, and they will put an X mark here, and they can ask you the shown drug X is showing what kind of activity. So you can easily choose it. Okay, so I hope it is clear, and this topic is done here. And as I have also mentioned that when you read this topic, make sure you read different types of antagonists, like competitive or pharmacological or physiological, chemical. Make sure you read that, or pharmacokinetic antagonist. Okay, on the basis of same, a drug desmopressin is a synthetic analog of ADH. Okay, it is preferred over vasopressin in the treatment of the diabetes mellitus for all of the following reason except. So what is that reason that we are actually choosing? So all of the following are good reason except desmopressin. Of course, it's a synthetic drug. It is more potent antidiuretic. We all know antidiuretic or vasopressin का analog है. It is selective V1 receptor agonist. It has little vasoconstricting ability. So like vasopressin has vasoconstricting, desmopressin also have, but is it little or more? You have to find out. It is longer acting. So you can tell me. Okay. What is inverse agonist? Arvind has asked a question. Inverse agonist, doctor, a drug will be binding with the receptor and producing negative action. Like for example, there is one if there is one receptor that is known to cause sedation. So if one drug, like let's say diazepam, is causing sedation, then another drug, if it is going to bind there on the same receptor, they will produce opposite action. Let's say beta carbolin. So beta carbolin is the inverse agonist of the receptor. So they will increase the wakefulness. ठीक है? Dr. Arvind, I hope I have clarified your query. Other students are marking B as an answer, some of you are marking C as an answer. So I'll quickly go ahead. See, desmopressin definitely is more potent. Desmopressin definitely is more potent. It is selective V1 receptor agonist. See, it's not V1 receptor antagonist. In fact, it is V2 का agonist. V2 के ऊपर desmopressin, it is actually synthetic analog of V2, and V2 agonist, they are going to increase the upregulation of the aquaporin, that will be increasing the reabsorption of the water. So that is how it is going to be effective in diabetes insipidus, where the patient is presenting with the polyuria, polydipsia. You can increase the reabsorption of the water inside the body itself, from the tubule inside the body. Okay, so not V1, which is a V1 receptor agonist, that is your terlipressin, like bleeding esophageal varices में we can use terlipressin is a V1 agonist. Okay, little vasoconstricting, of course it has little vasoconstricting. Okay, it is longer acting, of course. So desmopressin synthetic analog है, it's a synthetic V2 receptor analog, synthetic analog of vasopressin, or V2 receptor analog. So they are of course longer acting. The correct answer, all except me, it is selective V1 receptor agonist. No, that is wrong, right? So I hope इस तरह के tricky question भी आते हैं. So read the question very very carefully, and definitely you guys can get this done. Next one. 40-year-old man presented with the megaloblastic anemia and early signs of neurological abnormality. The drug most probably required is, so he is having two issues: megaloblastic anemia, and there is a neurological abnormality, neuropathies, let us say. I'm just putting it here, neuropathies. So which of the following you will be requiring? Folic acid, iron, erythropoietin, vitamin B12. Go ahead please, all of you. So you see, can we use folic acid? It's not like we can't use, definitely we can. So folic acid will be masking, this megaloblastic anemia, but neuropathy cannot be corrected. So one drug that you have to choose, all of you are actually marking correct already. So one drug that you are going to choose, it will be very well, vitamin B12. Vitamin B12 is a single drug that will take care of both the problem. Although megaloblastic anemia के cause, the cause can be two. There is a deficiency of vitamin B12 and also there is a deficiency of folic acid. So when we give folic acid, of course we can tackle the megaloblastic anemia, but of course we can see that vitamin B12 will be taking care of both the scenarios, right? So this was the question that was asked FMG. If I remember well, it was asked in 15-16, and I have given that in the FMG solutions as well. You can check it out. And options were not like this. Options were like vitamin B12, there was folic acid and then pyridoxine, and then they give a combination of vitamin B12 and folic acid. So that was the actually the most appropriate given that option that we had. So you can check it out actually. You can check it out. Correct answer is D. Very good, all of you guys. There's no point of giving erythropoietin, come on, iron sulfate for microcytic anemia, but here there is a megaloblastic anemia. Another very good question from the hematology. You started a patient on warfarin, oral warfarin. Which of the following factors show the most rapid decline in the blood levels after the initiation of the warfarin therapy? Okay, so this is a very good question, I would say. All the students, those who are live, please take part. And even if you're going to be right or wrong, doesn't matter, and don't be afraid of that. Don't be afraid of getting wrong. Nothing will happen. I'm not going to judge you guys. Okay, Zaid is telling B, Sushma is telling A. Okay. Okay, Nikhil is also in favor of B. Rutul B, Ashwati is in favor of D. Other students also please take part. जैसे ही question देखें, because in your real exam also I don't think you have more time than 1 minute, so around 45 to 50 seconds in reading, comprehending the question, and last 10 seconds आपको choose करना है, ठीक है? So I'm giving enough time to think and mark. Okay, so mixed responses are coming. B, D, dental Q is D, Siddharth Chavan is B, Nishta is okay. So let me just quickly talk about what is Warfarin. It's an oral anticoagulant and targeting what? Vitamin K dependent factor. It acts by a competitive inhibitor. That is also one of the term that was used in one of the NEET PG examination. It's a competitive inhibitor of vitamin K dependent factor. See, I am not using the term clotting factor. I am just using the term vitamin K dependent factors. And we all know that vitamin K dependent, we are having clotting factor as well, and we also have certain anti-clotting factor as well. Now, what are the clotting factor? We are having the favorite 1972, 2, 7, 9 and 10. Right? 2, 7, 9, 10. Anti-clotting factor will be protein C, and we are also having protein S. The first factor that is also decreasing. Which factor does decrease for the once you start the therapy, which is the first factor that decreases, guys? I'm sure all of you are aware that I used to say 7 is gone in 7 hours. Actually the term is 6 hours, but deliberately I'm using the term 7 hours here. So within 7, this is the first factor to decrease. First factor to decrease, that will be gone in around 6 to 7 hours. Then in around 8 hours, this is the second factor to decrease. Second factor that decreases protein CNS. Now do remember one more important point here, that factor 2 is the last factor to decrease, and this take around 4 to 5 days. This is the last factor to decrease, that take around 4 to 5 days. That means the complete action of warfarin will not come today. If you are going to start today, it will not come today or tomorrow. It will take around 4 to 5 days. Therefore, can you rely on warfarin in any emergency situation? That's another question. You will not, right? So the term that you learned here, that you will not be relying in emergency situation. That's point number 1. Second point, that if protein CNS is gone in 8 hours, if you see very clearly, there is a predominance of some factors like 2, 9 and 10 after 8 hours. After 8 hours, our 2, 9 and 10 are high. So in our body we have clotting, anti-clotting factor. So anti-clotting factor is gone in 8 hours. Now even though factor 7 is gone, but there is a predominance of some factors like 2, 9 and 10. You see, I am actually giving anti-clotting factor, but because of the predominance of factor 2, 9 and 10, we can actually see a condition known as your paradoxical clotting. There is increase in the clotting activity. So there is a paradoxical clotting here. We are giving anti-clotting, anticoagulants, but paradoxical coagulation will be seen. This is because of the predominance of 2, 9 and 10, and that is why, to prevent this one only, we are going to add heparin along with the warfarin. Add heparin in the initial first 5 to 6 days of the therapy, and after that withdraw it slowly. The complete action of warfarin is coming in 4 to 5 days. And because of this paradoxical clotting, examiner also asks that which of the following drug is associated with the purple toe syndrome. So that is the drug. Also given the term as a warfarin induced skin necrosis. So warfarin तो हमेशा से favorite रहा इनका, है ना? Warfarin induced skin necrosis. Also this is the example of a drug, zero order kinetics. Getting 0 in an examination is like a war. You put an end to this war. You unfractionated heparin, phenytoin, aspirin, ethanol like alcohol, tolbutamide, theophylline and warfarin. So warfarin is also one of the drug following zero order. Risk of toxicity is high, and especially with the enzyme inhibitors. So that is also one of the another question that was asked. So I hope all of you guys can give the correct answer now. It is not D, it is not C, it is actually protein C. So actually it should be 7, but 7 is not in the option. Again, 7 is not in the option, so the correct answer that is going to be is protein C, and that is why you are going to see this problem, purple toe syndrome and warfarin induced skin necrosis. In order to avoid this problem, we are going to add heparin. Clear है ना, the indirect thrombin inhibitor. Next one more question. Let's talk about one more question here. Which of the following prokinetic agent has been implicated in causing serious ventricular arrhythmias, particularly in patients who is on erythromycin or ketoconazole? So if you know which kind of drug is erythromycin and ketoconazole, then you can start getting towards the right direction. You can start picking the right answer here. There is a prokinetic agent causing ventricular arrhythmia, and as a matter of fact, it has been banned because of that reason. Erythromycin ketoconazole is which class of drug? I mean, with respect to drug interaction, think in terms of drug interaction. Thank you, Dr. Nikhil. That's a huge compliment. And all the other students, please go ahead and mark this answer here. Bilkul. So they are enzyme inhibitor, as I think Zaid has also said. They both are actually potent enzyme inhibitors, and we all know that enzyme inhibitors are known to increase the risk of toxicity. As simple as that. We all know drugs like your cisapride, mosapride, mosapride, drug like your tigacerod, they were actually banned because of this problem. What problem? QT prolongation. They were actually associated with QT prolongation, and this risk will further increase. Risk is increased with the enzyme inhibitor. Enzyme inhibitors are always known to cause. Enzyme inhibitors are also always known to increase the risk of toxicity. Now, which one is a safer here? See, they all are actually 5-HT4 agonists. Cisapride, mosapride, tigacerod, 5-HT4 agonist. In fact, prucalopride is also 5-HT4 agonist. ये भी 5-HT4 है और ये भी 5-HT4 है. But this prucalopride is actually not associated with any such arrhythmic events. Prucalopride is actually it is relatively safer, and therefore it can be used in multiple conditions, including conditions like, in what all condition we can use, including conditions like your opioid induced constipation. So whenever we have opioid induced constipation, you can get this prucalopride done. Or diabetic gastroparesis, we can use them, or we can even use this constipation dominant irritable bowel syndrome. Constipation dominant irritable bowel syndrome. Okay, so that is your prucalopride. Do remember, metoclopramide is a D2 blocker. Undoubtedly, it is also a prokinetic agent. It's also a prokinetic agent, mainly associated with your extrapyramidal symptoms. So आपके एग्जाम में भी पूछा है, एम्स में 2-3 बार रिपीटेड है. Which of the following prokinetic agent is associated with abnormal posture? The answer is your metoclopramide. Extrapyramidal symptom like your dystonia. Okay. They cross blood-brain barrier. Dr. Zaid. Metoclopramide crosses blood-brain barrier. It is the domperidone that does not cross. ठीक है? It is the domperidone that does not cross blood-brain barrier. Okay. So the one that is correct answer here, out after all the discussion about different drugs that we have, cisapride is the one that is going to be correct answer. है ना? ऐसे याद कर लीजिए, domperidone do not crosses blood-brain barrier. है ना? Domperidone do not crosses blood-brain barrier, so that you do not mix in the exam. Okay. Next one. A widely used drug that suppresses the cellular immunity, inhibits the prostaglandin and leukotriene synthesis, and increases the catabolism of IgG antibody. Okay, so that is a very easy one, I would say. Cyclophosphamide, prednisolone, cyclosporine, infliximab. Pretty simple one, but you should know about other options as well. Go ahead directly to your correct answer. Dr. Benedict is in favor of B. Other students also please take charge. B. Rameshwar is in favor of C. Payal is also in favor of B. Very good, very good. Leo, Raj Lakshmi, all of you are in favor of B. So I think it's pretty simple. that phospholipid converted to arachidonic acid, and this with the help of enzyme cyclooxygenase is converted to prostaglandin, and 5-lipoxygenase it is converted to leukotriene. And this phospholipid to arachidonic acid, the enzyme will be phospholipase A2. I think in your examination this has been repeated 4-5 times. Okay, from this particular area only. So quickly, we all know that phospholipase A2 inhibitor is going to be steroids. As a matter of fact, this inhalational steroids are, according to new GINA guidelines 2021, is the first line drug in bronchial asthma. You are supposed to give inhaled steroid along with the formoterol. So they are telling, according to older guideline, if you see global initiative for this bronchial asthma, if you see the older guideline, they say give steroid at the second step. At the step 1, don't give. But now they're telling, why are you waiting? See, since there's an inflammation, the chances that it can exacerbate any time, they are telling that as a step 1 modality itself, just start the steroids. So inhaled steroid or steroid is mainly simply a phospholipase A2 inhibitor. So if you are going to talk about inhaled steroids, there are many like budesonide, cyclosonide, flunisonide, fluticasone, all of them. What is cyclophosphamide, guys? Quickly, can you tell me what is cyclophosphamide? Correct answer is B, of course. All of you guys are very, very correct. What is cyclophosphamide? It is one of the, go ahead please. Cyclophosphamide kya hai? Very, very easy. It is one of the alkylating agent. Cyclophosphamide is one of the alkylating agent used in multiple condition. It's a cell cycle specific, cell cycle non-specific anti-cancer drug. Cyclosporin kya hai? It is one of the calcineurin inhibitor. Cycloserine tacrolimus, calcineurin inhibitor. What is infliximab? Ice and आग, mnemonic याद है? Ice and आग, ice के ऊपर आग, याद है? Infliximab, that is one of the TNF alpha inhibitor. So that is how you revise. You read, you look at the drug, even if you don't know much about that, at least know some points about those drugs that are very, very important, like infliximab, TNF alpha inhibitor. Okay, so I will be using in, let's say, in rheumatoid arthritis, inflammatory bowel disease. Likewise, calcineurin inhibitor in renal transplant patient, in inflammatory bowel disease, in rheumatoid arthritis, we can use them. Okay, quickly, COX inhibitor, we also know that it is going to be NSAIDs. So non-steroidal, steroidal will be phospholipase inhibitor, and LOX inhibitor, it is going to be Xileuton. Okay, so एक बार ये भी देख लिया आपने, they will be utilized in the bronchial asthma की prophylaxis में we can use them Xileuton, है ना? We can use Xileuton in bronchial asthma prophylaxis. ठीक है, steroid is the preferred agent or the drug of choice for bronchial asthma prophylaxis. Clear है? So every option has been clarified here. So sometime it will happen in the examination. I have seen that students are actually very good in ruling out some of the options, and that is also very good of approaching a question. And ruling out, and it's a very smart way of tackling some of the question about which you don't know. जिसके बारे में you know everything, it's direct, like this one. It's a direct. Prednisolone, we all know that suppressing the immunity, prostaglandin, leukotriene synthesis. You all know that steroid. Once you give steroid, and none of this pathway will proceed further. But when you learn to rule out options, that is another very good way of approaching the question. So you should know about these drugs. Okay, so the next one, you are about to start an anti-epileptic drug in a patient with epilepsy. Which of them is wrong about action of anti-epileptics? So you're thinking about starting, and when you're thinking about starting an anti-epileptic drug, you, let us say you thought about the pharma classes that you have attended on YouTube here. So can you tell me that what is wrong here? Very tricky, very easy. All of you, please give your own answers. Don't copy anybody else's answer. Give your own answer, please. Phenytoin, carbamazepine act by increasing sodium channel opening. Carbamazepine is preferred in trigeminal neuralgia. Diazepam, anti-epileptic property. Lamotrigine acts by blocking GABA mediated chloride channel. यहाँ पे GABA mediated chloride channel. All of you, please try marking. D, Ajmal, Himanshu, Sakshi, all of you in D. Muthu also D. Dr. Tej is also D. Okay, Zaid is in favor of C. Very good, very good. Benedict is also C. There can be multiple correct answer here. Chalo, I agree to the fact that yes, D is the correct answer. All the students like Benedict, Zaid, Villa, Sushma, can you choose one more option? Choose one more. D to agreed hai. D is correct, no doubt. So you have to choose one wrong. You have, if this is a multiple correct answer, which is the other question which will have. Okay, very good. So Lavanya, VG, you guys have picked that an important term here. See, phenytoin and carbamazepine, they do not increase sodium channel opening. They are voltage gated sodium channel blockers. So all the major anti-epileptic drugs that you can think of, valproate, phenytoin, topiramate, lamotrigine, carbamazepine, these are all voltage gated sodium channel blocker. They are not opener. They are not opener. Okay. Other is this is a correct statement here. Carbamazepine is preferred in trigeminal neuralgia. Yes, in fact, it is the drug of choice. Drug of choice for trigeminal neuralgia, drug of choice for glossopharyngeal neuralgia is going to be carbamazepine. Okay, diazepam has anti-epileptic property. Yes, it's a drug of choice for acute, for aborting any acute epileptic episode. It's a drug of choice. And for per rectal seizure also we are using them. Sorry, per rectal diazepam is used in febrile seizure. Per rectal diazepam is also used in febrile seizure. So definitely this is also a correct statement. C is also a correct statement. But which one is wrong? Lamotrigine act by blocking GABA mediated chloride channel. See, if you want to achieve a anti-epileptic property, you have to do two things. Aim number one, try to decrease the glutamate activity by blocking certain channels like voltage gated sodium channel, or by blocking glutamate receptor, or you try to increase the GABA by facilitating GABA mediated chloride channel. Do not block. We don't block GABA, and a GABA blockade will always precipitate the epilepsy. Making sense? So lamotrigine, by blocking any drug, if it is blocking GABA mediated chloride channel, definitely it can precipitate. So this actually is a dummy choice, or I would say wrong one. So if you are going to see multiple correct answer, so A and D are going to be correct answer, because these two are wrong statement. These two are wrong statement. Making sense? So पहले मैंने लिख दिया था multiple correct. So A और D इसमें दो होगा. ठीक है? So this type of question we have seen in the previous PGI Chandigarh kind of question. ठीक है? So इस तरह क्वेश्चन आए जहाँ पे आपको 2-3 wrong या 2-3 correct चुनने होते हैं. But what you learn from here is everything around these questions. ठीक है? That these type of questions can be in your exam. The topics. Pregnant female is always at risk of teratogenicity if exposed to drugs. Okay, that's a true statement. Most common cause of Mobius syndrome, okay, is use of which of the following drug in pregnancy? Okay, so Mobius syndrome is caused by which of the following drug commonly? Misoprostol, thalidomide, methimazole, and phenytoin. See, many drugs out of the choices can cause Mobius syndrome. Like thalidomide also can cause, but the examiner is asking most common कौन सा होगा? So most common, least common, ये कहीं जा नहीं रहा है. Although it's in case of in the form of clinical case, but it's gonna be there. I think all of you guys are very much familiar about this one. So misoprostol that we have, misoprostol, it's one of the PGE1 analog that is considered as a drug of choice in a patient with the not drug of choice per se. It's not the drug of choice, but it's a preferred drug, or I would say a specific drug. It's a very specific kind of drug in NSAID induced peptic ulcer disease. If you are going to give this for peptic ulcer disease, plus it is having some other use as well, like cervical ripening it can cause in pregnancy, and that is why it is always and always contraindicated in pregnancy. It can induce labor, and it is also associated with a side effect known as your Mobius syndrome, a teratogenic effect associated with other drugs like thalidomide, but most common it is your misoprostol. So misoprostol, Mobius syndrome. Now all the students, those who are live right now, be it NEET PG or INICT, on this platform YouTube itself, I have taken 2 sessions, part 1 and part 2, for the safer drug in pregnancy. So which is unsafe, what kind of teratogenicity it is causing, and what is the safer alternative. I have discussed, freely available on the platform. Check it out whenever you have time. And so even you can watch it at 1.25, 1.5, so that you can quickly revise. So all the areas like epilepsy, hypertension, what is unsafe, what kind of teratogenicity they are causing, and what is the safer alternative, antimicrobial, and a different system system wise I have given that, so you guys can check it out. Okay, great. Thank you, Dr. Benedict, and all the other students. I hope all of you guys are aware. See, thalidomide is phocomelia. We all know that. Methimazole is associated with what kind of side effect methimazole, guys? ये भी बता दीजिए, because ये भी important है. This is also going to be a part of revision. Methimazole क्या करेगा? एक side effect होता है जिसको बोलते हैं teratogenic effect, that is aplasia cutis. Phenytoin fetal hydantoin syndrome. फीटल हाइडेंटोइन सिंड्रोम. सो मैंने आपको बताया भी होगा, फेनिटोइन में एवरीथिंग बिकम टिन, है ना, बहुत छोटा हो जाता है, टाइनी. फेनिटोइन में हर चीज टाइनी हो जाता है. सो लाइक माइक्रोसेफेली, थिन अपर लिप, शॉर्ट नोज, है ना, स्मॉल फैलेंजेस, है ना, सो एवरीथिंग बिकम स्मॉल. क्लेफ्ट लिप एंड पैलेट इज अनदर फाइंडिंग. थैलिडोमाइड also is associated with the side effect that we all know is phocomelia, a drug that is having very huge historical importance, and we also know that currently it is being utilized for type 2 lepra reaction, erythema nodosum leprosum, and can also be it's also a approved drug for multiple myeloma. दो cases के लिए it has been reintroduced. So Mobius syndrome, of course, associated with 6th and 7th cranial nerve. The patient will have problem in moving laterally, and other condition could be associated with birth trauma. Misoprostol is the most common, you know, and thalidomide of course also due to exposure to cocaine, that can also cause Mobius syndrome during the pregnancy. Okay, so the other teratogenic effect. Okay, another easy peasy question will be this: a person is taking tricyclic antidepressant and presenting with the blurred vision, okay, dryness of mouth. This side effect is due to blockade of which receptor? By the way, this is the part 1 of the case series today. Tomorrow again same time I will be meeting you here with the part 2. So if you guys are free, please join tomorrow's session as well in part 2. That is tomorrow 10 PM again part 2 will be covered. So tricyclic antidepressants, example of drugs that we are having is imipramine, trimipramine, desipramine, clomipramine, amitriptyline, and nortriptyline. How do you remember, guys, all these drugs? Because sometime in your examination you see a previous 2015-16 question, they ask you to choose which is a SSRI, which is an SNRI, which is a TCA. Anyone who attended my session before, can you tell me how do you remember? What's the mnemonic for remembering the side effect, the drugs under this one, TCA? Imipramine, I try, Desi Club for 2 more, that is Amy and Nori. I am trying for 2 more, so we become 3 actually, and I am trying for 2 more, Amy and Nori. So I try Desi Club for Amy and Nori. Imipramine, trimipramine, desipramine, and I try Desi Club for Amy and Nori. Now these tricyclic antidepressant, usually in a depression it is just second line in depression. Why in second line and we are preferring more SNRI and SSRI? Because of their multiple side effects. Like for example, they are having H1 blocking property, because of that they will be having sedative. They are having also anticholinergic property, because of that if it is in the eye they will be causing blurred vision. If it is the gland they can cause dryness, and anticholinergic effect, blurred vision, dryness of mouth. Plus they are also having alpha 1 blocking property that can cause postural hypotension, and any drug causing postural hypotension can also induce your reflex tachycardia. It can even lead to your reflex tachycardia. Plus it is also associated with a metabolic problem like metabolic acidosis, and guys, isn't that metabolic acidosis is associated with arrhythmia? So this is a pro-arrhythmic drug, and metabolic acidosis induce arrhythmia in a TCA poisoning, another question that has been asked in your examination. a patient presented with this and there is a TCA poisoning. First of all, let me answer this question: why there is blurred vision? It is because of muscarinic antagonist, है ना? That is a blurred vision because it's a anticholinergic acetylcholine का receptor होता है, muscarinic receptor, that is causing M3 receptor blockade. Not the GABAergic or epinephrine or N receptor. They do not have activity over these receptors. Okay. Definitely you should start, है ना? And if you have read your notes, then red plus FMG solution is always the most recommended tool for your preparation. So TCA poisoning में क्या use करते हैं? If the TCA poisoning, the patient is presenting with your arrhythmia, what will you do? Do we have any antidote? No. So what we do, it's acidic drug, so we cause forced alkaline diuresis. Forced alkaline diuresis. So you will be doing forced alkaline diuresis using what? Sodium bicarbonate. In fact, you can even use carbonic anhydrous inhibitor. So that's another question. Okay. So sometimes question like this can also be framed. Depression wala case hoga, plus the question will be mainly associated with the basic or autonomic nervous system wala question aa sakta hai. Next one. Valproate exposure to a pregnant mother causes all of the following teratogenic effect in baby except. Methotrexate के लिए mainly we use leucovorin or folinic acid. Go ahead, please. Valproate exposure to pregnant mother causes all of the following teratogenic effect in baby except. Yes, Dr. Benedict. Right? So this is what we do. Actually, the more we do the question, the more we make mistake and we learn from our mistakes. Go ahead, please. All of you, please. So I think most of you are marking A, some of you are marking D. Then there are also people in favor of C. See, spina bifida, or I would say valproate, it's the most teratogenic anti-epileptic drug, I believe. Yes or no? It's the most teratogenic, and that is associated mainly with your spina bifida. Yeah, no? Spina bifida is a type of neural tube defect, and this is the most teratogenic drug. So when we are having all except in the baby, see, polycystic ovarian syndrome or polycystic ovarian disease is a side effect caused by valproate. There is no doubt about that. There is no denial about that. But the question is asking in the baby, not in the baby. Baby में तो teratogenic effect होगा. This can be seen. It is actually associated with valproate, but it can be seen in the pregnant female or any female. है ना? It is associated with valproate, and it will be seen in the patient herself, right? Female patient, and it will be seen in the female patient itself, not in the babies. Making sense to all of you? So correct answer for this question is going to be PCOD, not neural tube. Definitely it will be causing neural tube defects, spina bifida, or the CVS anomalies. Okay. Yes, in the April first week on the platform, on the Unacademy platform, we'll be starting, this particular revision for FMGE students and also for NEET PG students. Okay, so the next one, 60-year-old female diagnosed with osteoporosis. Drugs used for the osteoporosis are all except. Go ahead, please. A 60-year-old female diagnosed with osteoporosis. What are all of the following drugs are used except? Parathyroid hormone analog, strontium renylate, denosumab, methylprednisolone. What will you not use? Very nice, excellent. So I see many of you are marking, and you all are in favor of D. There are some people in favor of A also and B also. See, parathyroid hormone analog in a severe osteoporosis, especially in postmenopausal women, more than 5 years of postmenopause, those who have achieved, we are preferring this one. Parathyroid hormone analog, that is known as your teriparatide and abaloparatide. Teriparatide and abaloparatide. In fact, this is the only agent that is having bone anabolic effect. They are anabolic in nature. They increase the osteoblastic activity. They are used actually. Strontium renylate, actually, can be used of course, but it's not preferred because of the DVT. And strontium granulate, it inhibits the osteoclast and it also stimulates the osteoblast. The side effect that we are having is DVT. Because of that, in some countries it is banned. Okay? Denosumab, of course you all know that this is the rank ligand inhibitor, and do not allow the activation of osteoclast, inhibit the osteoclast activation. It inhibits the osteoclast activation. Methylprednisolone is a very notorious drug. Long-term use of methylprednisolone steroid are associated with the osteoporosis. So they themselves causes osteoporosis. In fact, steroid-induced osteoporosis, they themselves causes osteoporosis. It's an example of type C ADR, type C kind of ADR, chronic. So chronic use of this steroid can cause osteoporosis. It's an example of type C ADR. Making sense to all of you? Yes. So steroids not used for the management. They themselves cause osteoporosis. The most common side effect of cancer chemotherapy is nausea or vomiting, with or without vomiting. The anti-cancer drug vary in their ability to cause nausea or vomiting. Which of the following anti-cancer drug is least likely to cause nausea or vomiting? Okay, so that's a little atypical kind of question. Go ahead please. Which will be causing or least associated with nausea and vomiting? Chlorambucil, cisplatin, doxorubicin, daunorubicin. Okay, so I can see B, some of you are marking D, some of you are marking A, C. Okay, so first of all B, least पूछ रहा है ना, least likely, तो आपको केयरफुल रहना है क्वेश्चन पढ़ते समय. सिस्प्लाटीन इन फैक्ट इज द मोस्ट हेमेटोजेनिक एंटी कैंसर ड्रग. 2021 FMGE में पूछा फॉर द प्रोफाइलैक्सिस व्हाट विल यू यूज फॉर द नोजिया एंड वॉमिटिंग. We always had 5-HT3 antagonists. In fact, prior to infusion of the chemotherapeutic agent, we add drugs like ondansetron, paranosetron, granisetron. These are the 5-HT3 antagonists that we always used for the prophylaxis and the treatment of chemo-induced nausea and vomiting. Or in fact, any nausea and vomiting, these are the drug of choice. Okay, these are the drug of choice. Chlorambucil, these are associated with least hematogenic. Among anti-cancer drug, it is said to be least hematogenic. See, all can cause nausea and vomiting. Anything and everything that you're taking from outside can induce nausea and vomiting. ठीक है, chlorambucil जो है least hematogenic है among anti-cancer drug. Okay, so two type of question has been sorted here. Next one. Which of the following anti-tubercular drug can cause shown laboratory profile? So what is the laboratory profile that is seen here? TSH level is high and T3 level is low. So elevated TSH level and decrease in the T3 level, this is a typical finding of which kind of thyroid problem? TSH किस में बढ़ा रहता है? And which drug can actually lead to this kind of problem? All of you please try. Rifampicin, pyrazinamide, ethionamide, streptomycin. Students are in favor of A, C. Okay, A. There are also people in favor of A or C. Okay. So first of all, this is a case of hypothyroidism. An examiner is very simply asking which can cause hypothyroidism. So hypothyroidism among anti-tubercular drug, in my almost every TB class I used to tell you that usually associated with para-aminosalicylic acid and also associated with your ethionamide. So these two drugs. Out of the given one, ethionamide is the one. And streptomycin will be causing higher ototoxic. It's a very, very ototoxic drug, and also it is going to be a highly nephrotoxic agent. Plus it will also cause neuromuscular blockade. Pyrazinamide, it's a highly hepatotoxic drug. In fact, among the first line, it is the most hepatotoxic drug. Most hepatotoxic. Pyrazinamide. Rifampicin is going to be, rifampicin, it is having some harmless side effects like red-green urine discoloration. Red-orange actually. Red-orange urine discoloration plus they are also hepatotoxic. They are also hepatotoxic in nature. Red orange urine, hepatotoxicity, and a flu-like symptom, that is also. Pyrazinamide can also increase the level of uric acid. तो मैंने आपको निमोनिक बताया भी होगा, प्यार दर्द भी देगा. सो व्हाट आर द 5 पॉइंट्स अबाउट प्यार दैट आई ऑलवेज टेल यू. प्यार के बारे में 5 बातें important that I always tell you. 5 points to remember about pyar. Do not forget. Point number 1, that no matter what happen among the first line drug, you always have to keep the dose high. pyar का dose सबसे ज़्यादा रखना है 25 mg per kg. Point number 1. No matter how much dose you keep, it is going to be most hepatotoxic. 5 points about this. Most hepatotoxic. सबसे toxic है. We prefer pyar intracellularly, inside. Pyar is preferred inside. It's a drug that is highly effective intracellularly. For the intracellular mycobacterium, it is highly effective. तीसरी बात हो गई प्यार के बारे में. Then you avoid during the pregnancy. It's a drug that should be avoided during the pregnancy. And 5 point, प्यार दर्द भी देगा, so they can increase the uric acid or precipitate gout. तो ये 5 बातें मैं pyrazinamide के बारे में बोलता हूँ, और मैं जानबूझ के pyrazinamide को pyrazinamide बोलता हूँ, so that you remember like that in the exam. That प्यार है ना, डोज हाई रखना है, टॉक्सिक भी होगा बहुत, इंट्रासेलुलरली प्रेफर करना है, अवॉइड करना है प्रेगनेंसी में, और दर्द देगा, ये तो सबको पता है. ठीक है. सो प्रेसिपिटेट गाउट. सो 5 पॉइंट्स अबाउट pyrazinamide, डू नॉट फॉरगेट. ओके. सो डिफरेंट साइड इफेक्ट भी एक बार क्विकली आपने देख लिया. मूविंग ऑन टू द नेक्स्ट वन. 55-year-old पेशेंट प्रेजेंटेड विद अ डिक्रीज इन द विजन and visual field defect and diagnosed with the open angle glaucoma. Okay, so diagnosis has been given. Which of the following drug act on the trabecular meshwork and affect the aqueous outflow? Okay, acting on the trabecular meshwork and affecting the aqueous outflow: timolol, pilocarpine, brimonidine, brinzolamide. आउटफ्लो की बात हो रही है, ध्यान रखिएगा. वेरी इंपॉर्टेंट पॉइंट. दे आर टॉकिंग अबाउट आउटफ्लो हियर, बिकॉज इफ यू वांट टू डिक्रीज द एक्वस प्रोडक्शन फ्रॉम द पार्स प्लिकाता ऑफ ciliary muscle, that is actually producing aqueous at a rate of 2.2 microliter per minute. If you want to decrease the production, then I used to give you very simple mnemonic, like as simple as ABCDE. They are the ABCDE as simple, like alpha, alpha blocker like apraconidine, brimonidine. Then your beta blockers, timolol, betaxolol, carbonic anhydrase inhibitor, like dorzolamide, highly preferred in pediatrics. D is a dipivefrin, that happens to be the prodrug of epinephrine. Okay? So they are actually having dual property. They are having dual action. That means they decrease the production, that is point number 1, and they also increase the outflow. Okay? So the good news is we don't have dipivefrin or epinephrine in the option. Timolol, beta blocker, of course I have told you they are going to decrease the production. Pilocarpine, it's a M3 receptor agonist, and do remember, for increasing the outflow, you are having 2 ways. One is the traditional method. Traditional is trabecular, so increasing the trabecular outflow, and alternative is uveoscleral. Now what is the problem in the glaucoma? The trabecular meshwork is already blocked due to degenerated retinal pigment epithelium. The trabecular meshwork is already blocked, and that is why the outflow has been compromised and intraocular pressure has increased. In a normal person, in you and me, trabecular meshwork is taking care of 70% of the aqueous outflow. Okay? For example, let us say, although it's never gonna happen, but I'm just telling you, if 100 ml aqueous is there, 70 ml will be the outflow will take outflow will be by the trabecular meshwork, and 30 ml will be by the uveoscleral. But since trabecular is blocked, we actually prefer uveoscleral only. Okay? That is why all the drugs or the drugs that are increasing the uveoscleral pathway are the drug of choice. Okay? Overall best drug, most powerful anti-glaucoma drug of choice, and uveoscleral वाले. I'll tell you, very easy way to remember. जैसे ये ABCD आपने याद किया, in that way I want you to remember P and PA. देखिए इससे आसान कुछ नहीं होगा. P and PA stand for your pilocarpine, and epinephrine. As I have also mentioned, epinephrine is increasing the outflow. PA stand for your PGF2 alpha analog. Drugs like your latanoprost, bimatoprost, tafluprost, travoprost, they are all, and A stand for your alpha 2 agonist. So I hope you guys can easily understand A, B, C, D, E, P and PA. And now let's go to the question. Which drug can increase the aqueous outflow? Timolol decrease production, not affecting the outflow. Pilocarpine increasing the outflow. कौन सा outflow? Trabecular outflow, the traditional method. Brimonidine is what? Alpha 2 agonist. Apraclonidine, brimonidine. So these are mainly associated with your decreasing the aqueous production. Brinzolamide, they are mainly the carbonic anhydrase inhibitor. So if you are going to choose, there can be two answers here as well, like B and C, but the most preferred is always going to be B, because pilocarpine is a very commonly used drug, and pilocarpine of course is available by OcuCert. One of the newer drug delivery method is your OcuCert. So that will continuously supply your M3 receptor agonistic property, and therefore they will be causing the meiosis. Now since the age is 55, always remember this alpha 2 agonist is contraindicated. Alpha 2 agonist, this is not blocker actually, ये hashtag sign नहीं है, ये blocker है. Sorry, alpha 2 agonist, we will not be using blocker. Alpha 2 blocker we don't use, like UHIMBIN we don't use. Alpha 2 agonist है, ठीक है, beta blocker carbonic anhydrase. So elderly और pediatrics में is contraindicated. So 55-60 year old male है ना, उसमें alpha 2 agonist, because they are causing drowsiness, we don't prefer them. ठीक है. So which of the following drug will be preferred? The pilocarpine you can use. Okay. Next one. Which of the following is true about antagonist? I think I have already discussed this one. You guys can easily give me the correct answer for this one. What is true about antagonist? It has no intrinsic activity, no affinity, has high intrinsic activity, high affinity, has submaximal intrinsic activity, submaximal affinity, no intrinsic activity, high affinity. A, B, C, D. I have discussed this. In fact, this was the first question today related to drug and receptor. Now I am specifically talking about antagonist. Okay, Arvind is in favor of D, Gaurav also in favor of D, Vici D, Benedict Delta, very good. Other students also, please try, take part, don't be afraid. Rutul, Nikhil, and all of you in favor of D. So I think that's pretty simple. No intrinsic activity because it simply blocked, does not produce any activity. Intrinsic activity is 0 and has high affinity, of course. So that is your antagonist. Submaximal intrinsic activity are partial agonist. High intrinsic activity will be agonist. No intrinsic activity will be antagonist, but affinity hai. They are telling no intrinsic and no affinity. No, affinity is there. Okay. So that is another very simple question. Hypomagnesemia due to increased excretion by the kidney is caused by all except. We are about to finish 2-3 more questions and then we are done. Hypomagnesemia due to increased excretion by the kidney. Increased excretion of magnesium by the kidney is caused by all except. ट्रिकी है, आसान भी है, दोनों टर्म्स में यूज कर रहा हूं. लिटिल ट्रिकी, लिटिल इजी. एक्सेप्ट को मैंने अंडरलाइन किया, ध्यान दीजिएगा. सो आई थिंक मोस्ट ऑफ यू, मनीष, अंजलि, राजलक्ष्मी, सब लोग ट्राई करिए. जितने लोग लाइव हैं सब लोग ट्राई करिए. मोस्ट ऑफ इन फेवर ऑफ सी. अदर स्टूडेंट्स टेक एटलीस्ट 30 सेकेंड टाइम, थिंक एंड मार्क. Furosemide, you can think, okay, it's a loop diuretic, will it cause loss of magnesium? And digitalis. Alright, so let's save some time here. Most of you, all those who have replied, are in favor of C. Masood are in favor of D. Okay. Now do remember that hypomagnesemia is a side effect. All of you are actually telling C. और सी के साथ सबसे कॉमन है ना. रीनल ट्यूबुलर एसिडोसिस विद हाइपोकैलेमिया एंड हाइपोमैग्नीसीमिया, ये इतना कॉमन, इतना क्लासिकल साइड इफेक्ट है कि ये इरिवर्सिबल है और कई बार पूछा हुआ है ना. और बहुत बहुत ही फेमस आई मीन ये साइड इफेक्ट है ना. मोस्ट ऑफ द स्टूडेंट्स इफ यू आर अटेंडिंग मेडिसिन क्लास उसको उसमें बहुत स्ट्रेस करके पढ़ाते हैं, है ना. एम्फोटेरिसिन बी इट्स अ इरिवर्सिबल काइंड ऑफ साइड इफेक्ट, है ना. इरिवर्सिबल है ये, इरिवर्सिबल रीनल ट्यूबुलर एसिडोसिस, है ना, with hypokalemia and hypomagnesemia. When the amphotericin dose crosses more than 4 gram in a single go, then it can cause. And cisplatin can cause, furosemide will also be causing. Furosemide is a loop diuretic, it causes, you know, loss of all the electrolyte, like loss of calcium as well, loss of potassium as well, loss of magnesium as well, loss of sodium as well, सबका लॉस कराएगा. ठीक है. Now digitalis, hypomagnesemia increases the risk of digoxin toxicity. That's a different term. Listen to me very, very carefully. If there is a patient with the hypomagnesemia, they can increase the risk of digoxin toxicity, but digoxin themselves does not cause hypomagnesemia. In fact, digoxin का जो एक side effect होता है related to electrolyte imbalance, that is hyperkalemia. ठीक है. It can cause hyperkalemia. That is one side effect. But it does not cause hypomagnesemia. However, in a patient with the hypomagnesemia, the risk of digoxin binding with the sodium potassium ATPase will increase because magnesium is a cofactor for sodium potassium ATPase. So if hypomagnesemia is there, the risk of digoxin binding with the sodium potassium ATPase will increase. ठीक है. So they themselves does not cause hypokalemia because the question is saying increase excretion. Others can increase. Cisplatin is a nephrotoxic drug. They increase the risk of electrolyte. They increase electrolyte loss, including magnesium. Amphotericin B causing renal tubular acidosis. They cause hypokalemia, hypomagnesemia. It's a very classical. मतलब अगर मुझे इसमें से एक चुनना हो, which drug is more commonly, I will be choosing amphotericin B. है ना. Furosemide, of course, it's diuretic. Definitely, it will also be causing. ठीक है. So these are the important drugs like loop diuretics, as I have told you, aminoglycoside, and antimicro like amphotericin B that we have, and a cisplatin as well, plus others like tacrolimus and cyclosporin can also cause this. So important points I have highlighted here. Okay, in the causation of osteomalacia, which of the following drug is involved? Easy yet tricky. So when I say this, be careful. Phenytoin, glucocorticoids, heparin, teriparatide. You are about to finish. I think this is the last question or second last question possibly. Go ahead please. All the students, those are live. सब लोग ट्राई करिए. डी, टेरिपेराटाइड. क्वेश्चन को फिर से पढ़िएगा. Which of the following drug is implicated in the causation of osteomalacia? Which drug in fact increase the risk of osteomalacia or causing osteomalacia? Okay, so correct answer is given by many of you. I will quickly give you. Phenytoin, actually it is going to, it's a very, very potent enzyme inducer guys. ठीक है. And also it is going to increase the vitamin D का metabolism as well, and therefore there will be increased risk of osteomalacia. Phenytoin can increase the risk of osteomalacia and it can also increase the risk of fracture. Steroids, heparin, they can actually increase the risk of osteoporosis. They are very commonly associated with the development of the osteoporosis. Teriparatide is not the correct answer. D क्यों चुन रहे हैं आप लोग? Teriparatide, it is used in treatment of osteoporosis. Used in treatment of osteoporosis. ठीक है. Via injectable routes, है ना, inhalational route भी available है, subcutaneous routes available है. Teriparatide, abaloparatide, they are the recombinant parathyroid hormone analog. ठीक है. कहना मुश्किल होगा because whenever we are using this, we are always using the in the low dose. ठीक है. तो लो डोज में they will be actually inducing your osteoclastic activity, and whenever there is a little increase in the osteoclastic activity, there is a massive increase in the blastic activity. So they are actually a bone anabolic drug. Bone anabolic, so they cause bone formation. ये खुद ही bone anabolic है ना. So they increase the bone anabolic. However, in toxic doses, if it is taken, if it is high doses, they can increase the risk of also osteoporosis, you know? But not malacia. Malacia is mainly phenytoin. Okay, second last question. Which of the following agent is used in osteoporosis associated with the DVT? In osteoporosis, of course, I'm sure all of you guys are aware that drug of choice that we use is a bisphosphonate, like alendronate. All of them are ending with the dronate, alendronate, risedronate. And another thing that they are asking is about the side effect that they can cause, peptic ulcer disease or esophagitis. That is why we do not allow the patient, do not always advise the patient to take the drug and maintain upright posture for another 30 to 40 minutes. Then another side effect that they cause is jaw necrosis, osteonecrosis of the mandible, also known as jaw necrosis. So that is another side effect. Okay. Strontium ranelate, this term I have used in one of the questions, just 10-20 minutes ago. There was a question in that I told you that they are banned in some countries because of this side effect. Denosumab, as a matter of fact, rank ligand inhibitor, it is also associated with certain side effect, like again peptic ulcer disease, same as bisphosphonate, esophagitis, and they are also associated with side effect like jaw necrosis. So ये side effect associated इनके साथ भी है, do remember. So any drug of any case of the osteoporosis, be it postmenopausal women, premenopausal women, सब में bisphosphonate is the drug of choice. ठीक है? Okay, last question that we are having is this one. Which of the following agent has mixed alpha and beta agonistic properties? Promise this is the last question and then we can go home after this. Which of the following has mixed alpha and beta agonistic property? Very easy question. Dobutamine, epinephrine, phenylephrine and phenoldopam. You can go ahead with the Masood, Zolendronate and all. They are very, very potent. Potency is around 5,000 times as compared to the etidronate. Sushma, sorry, B, all of you are telling okay. Mixed alpha and beta, epinephrine. Subhalakshmi, epinephrine. Okay, very good. So I think most of you are getting correct. Some of you are actually marking A as well. So dobutamine, it's a selective beta 1 agonist. Epinephrine, of course, we all know that it is alpha and beta agonist both, alpha 1, alpha 2 agonist, and also beta 1, beta 2 and beta 3 agonist. Sub pe agonist hai ye. So alpha and beta agonist is this. Phenylephrine is just alpha 1 agonist. They are going to cause vasoconstriction. Phenoldopam, it's not alpha and beta, it's mainly D1 agonist. Phenoldopam. So in fact, USMLE में question भी पूछा, which of the following drug is acting via GS and it is utilized in a hypertensive emergency with the renal failure. So it was phenoldopam actually. It can also be used in hypertensive emergency with the renal failure. Alpha only is phenylephrine. Epinephrine, this is very easy question. See, so कई बार ऐसा होता है कि आपको लगता है यार एपिनेफ्रिन में क्या पूछेगा, और एट्रोपिन में क्या पूछेगा और क्लोरिडिन में क्या पूछेगा. तो एज सिंपल क्वेश्चन एज लाइक दिस एंड एग्जामिनर कैन ट्रिक यू विद दिस क्वेश्चंस. सो मिक्स्ड अल्फा एंड बीटा एगोनिस्टिक प्रॉपर्टी एपिनेफ्रिन. ठीक है, बाकी सबका मैंने आपको बता दिया. देन आई एम श्योर ऑल ऑफ यू गाइस आर अवेयर आइसोप्रेनालिन और आइसोप्रोटेरेनॉल, दे आर द सेलेक्टिव बीटा एगोनिस्ट लाइक बीटा 1 बीटा 2 एगोनिस्टिक ड्रग. That is also that you should know. Okay, so that will be all from my side in our today's session. And tomorrow, that is 10 p.m. 30th April, again we'll be discussing about part 2 of the most expected question. Part 2 of the most expected question. So different topics, we'll be having more clinical cases tomorrow as well at 10 p.m. again and 1 hour again. 1 घंटा YouTube पे कल भी हम मिलेंगे और ये सारी बातें फिर से करेंगे. I mean not this but of course the newer question, different topic, so we'll have more antimicrobial वाले question, cancer वाले question, and other very important areas like ANS से भी काफ़ी question आते हैं, so उसको हम कल cover करेंगे. Thank you very much to all of you for your presence and attendance and all your active participation. We are not actually allowed to share but you can search it out, you can easily find it, you can easily find me. ठीक है, Masood. ठीक है, so have a good night to all of you. I'll see you tomorrow. Any question you can also ping me in any of our social media handles. Bye bye to all of you.